Okay. So I think we'll get started, doctor, with your permission.
Just give me 1 minute, sir.
I'm ready anytime.
Yes, sir. You can start now.
Okay, great. So a very good evening to you all. I am Dilip, General Manager, Liva Division for Zydus. So, Doctor, each one of you, I welcome you for this special session under DermaQuest from Zydus Liva. So, as we all going through this pandemic, and this is almost we are more than a year and a half is over, but still the fight against this COVID-19 has been one of the great, and I really salute to each and every doctors who are really putting their great efforts in the fight against COVID. So during this period, let me also share with all of you, Zydus has been always at the forefront in putting the best efforts in this fight against COVID-19, be it in terms of launching innovative product, research product, specifically to reduce the patient's hospitalization as well as to have a betterment and the recovery from COVID-19 has been great. Like Virapin has been our original research product, and as well as our vaccine, which is indigenized vaccine, is in the process of getting approval. And we are proud that it will be one of the first vaccine also targeted for the pediatric age group and giving them the relief for fighting against this COVID. So, doctors, we are very sure that with your efforts and the efforts of like a company like us, we should be able to win over this pandemic and come out of this situation of challenging times. And we are look forward that we should come and meet in person for the actual CMEs in person, because of course in the last over an year and a half we are meeting on the webinars like this, but yes, there is no replacement for the webinar wherein all we can meet personally. But yes, I think this webinar will help us to connect at your own convenience, at your own place. So first of all, I really appreciate for all the doctors taking their time and joining for this session for today's discussion. So doctors, today's discussion is purely on one very special kind of a topic. I'm sure I think all of you must be getting a lot of webinars day and day night and many multiple weeks. But yes, something which can really add value for the newer perspectives, for newer formulations and the newer treatment modalities. I think that will definitely very, very interesting. So that's why I really welcome you all for this special Dharma meet, for the super meet, talking about super bioavailable Heteroconazole and Indian perspective. So doctors, let me share with you also one more thing. At Zydus, we introduced our Heteroconazole with the brand name Mycological in 2018. Of course, not very early because this molecule has been quite in the market more than 3 decades. However, with our Zydus quality, we could really grab the gold award from the agency where even the government of India depends, that is AWACS, for giving us that gold award for our best quality and the prescription by the dermatologists across the country. So that's how, sir, and one and all, this Heteroconazole has played a big role in the fight against tinea, particularly the tinea becoming more recalcitrant and more challenging. I think in that situation, Heteroconazole changing its mode and changing its phase will be always an advantage in this fight against tinea infection as well. So I welcome you all once again for this session, and I request our medical advisor, Dr. Ashok Jaiswal, to introduce our prominent speaker and set the context for the meeting. So over to you, Dr. Jaiswal.
Right, thanks, Dilip. Thank you so much. So hello and very good evening. It's indeed an absolute pleasure and privilege of mine while being a part of our today's webinar on the topic super bioavailable Heteroconazole and Indian context, because the Indian context is important. Why? In India, we are battling with increasing burden of recalcitrant dermatophytosis, difficult to treat dermatophytosis. And this problem is getting bigger and bigger nowadays. Another challenge which we are facing today in India is a rising prevalence of drug resistance in the management of dermatophytosis. Many data from India emerging, they suggest that there has been a gradual rise in the prevalence of resistance to antifungal agents like terbinafine, griseofulvin, fluconazole with a proportionately high MIC value. However, the MIC value of heteroconazole is still very low, and hence it plays a very crucial role, a major role in today's scenario in the management of difficult to treat or recalcitrant dermatophytosis in India. At one end of spectrum, the responsible fungi are posing a great threat to us. However, at another end, we and our rapidly developing medical science are also taking head-on with this rising threat from this microorganism. There has been a surge in the usage of innovative technologies in the field of pharmaceuticals nowadays, and it has led to many innovative drug formulation which we have got in recent past. And today we are going to discuss about one of such innovative formulation which is embedded with innovative technology used in the making of heteroconazole. Dear all, today I am honored to have an eminent consultant, eminent speaker amongst us who would be presenting us on this new innovative formulation of heteroconazole. And let me take this opportunity to introduce our today's speaker, who as such requires no any formal introduction to this part of world. We have amongst us Professor Dr. Manjunat Shinoye. Dr. Shinoye is a head of the department from Yenepoya Medical College, Mangalore. Dr. Shinoye is a past president IADVL Karnataka in 2015. He has been a vice president IADVL National 2020. He is a coordinator of IADVL SIG Recalcitrant Dermatophytosis 2021. He has been academic chairman for IADVL Karnataka 2019 and 2021 currently as well. Professor Shinoye has many accolades to his credit, including one which is mentioned here on the screen. He has received IADVL National President's Appreciation Award for the year 2018. Many publications to his credit, and that speaks about his interest in the research and the science. Almost 84 publications in national and international journals of repute, 2 books, 13 chapters, 10 clinical trials, and 1 patent. That's what Professor Dr. Manjunat Shinoye we have with us. So thank you so much, Professor Shinoye, for being with us today evening. Now, without any further delay, I would like to hand over the session to you. Professor Shinoye, over to you.
Thank you, Dr. Ashok Jaiswal, for those ice-breaking the session with those very good introduction. Thank you, Mr. Sonawane, for your expressing the commitment of Zydus, and not just towards the issues that dermatologists bother, but also to a major cause that is vaccine development. I really appreciate the initiatives, and I really wish the vaccine comes early and our pediatric children also, they'll be able to attend the schools physically, and they perform as well. Thank you, my friends in Zydus, for this invitation. Thank you, Dr. Bhagyashree, Kush, Manish, everyone. So it's a nice evening meeting with though virtual, but this has become the new normal for us, and hence we are quite acquainted with this. And today we are discussing, as Mr. Sonawane mentioned, that it's a new formulation that is called super bioavailable heteroconazole, and its context and its why it is so important for us to have this new formulation in the current Indian scenario. This super bioavailable, which is called as Suba heteroconazole in Australia and USA, which was 2018, it got approved. And the very fact that within 2 to 3 years, it has been brought to India with the proper channel, not by just making a yet another generic. It has to undergo certain norms, which means the quality assurance has to be there with this particular formulation, being it's a new molecule. It's not that anybody can it's not off patent molecule, anybody can produce it and market it. No, it's not easy. So that way, that's the first context I would set in Indian market. When you bring something, if it is still in the process of patent, it's still in, and then it's always anything that comes, we can fairly assure that quality is there. That's the first thing. And second thing is that we all know that nothing new has come up in the uh, treatment of dermatophytosis for decades, except for a few newer topicals like livaconazole, maybe Heteroconazole, or a few of them. Apart from that, nothing new has come, and which is grossly insufficient considering the magnitude of problem that India is facing with the recalcitrant dermatophytosis. The prevalence pool of recalcitrant dermatophytosis is kept on adding by the cases that mismanaged. Many of them are mismanaged, and that gets into a phase of chronic dermatophytosis, recalcitrant dermatophytosis. So it keeps adding. It's not possible that every patient with dermatophytosis can come to dermatologist. It's not possible at all, because the magnitude is the problem is so big. So it's quite possible that a lot of patients, for various reasons, maybe because of financial constraints, so they often buy these over-the-counter products, and they all add up to the pool of prevalence of recalcitrant dermatophytosis, which makes it very difficult for us to handle. And we are really looking forward to something new, something that can be relied upon. And this is a great welcome to Indian market, the super bioavailable Heteroconazole. We all know that dermatophytosis, we don't have to go in depth about, because I'm sure this may be the webinar number N for you all, yet another webinar. So don't like to be yet another, but just to understand, we have these species and newer genera are described of late, Arthroderma, then so many others. So, but however, these are the three prevailing genera in India. We have the Trichophyton mentagrophyte, undoubtedly is the most frequently isolated in the current scenario, followed by rubrum and certain other species, including few microsporum species as well. So these are the various clinical syndromes which can be associated with dermatophytosis. What's important, what I understand in this particular epidemic of dermatophytosis in India is that we don't get to see a lot of hair involvement, or the tinea capitis hasn't changed much, or onychomycosis, or the beard hair. That means again the hair infection. So what we are actually facing is the glabrous skin infections like groins, the lower abdomen. Again, tinea manum, the classical tinea manum. You may have a tinea corporis extending into the hand. We do get to see them, but the classical tinea manum or PDs is not so common. So what we are facing is basically the glabrous infections of the groin, abdomen, and also face. We see a lot of tinea facial. Now this particular disease has percolated into all sections of the society. It involves as even 15 or 20 days old infant to a 90-year-old man who is often bedridden. Also, you get to see in the hospital. You go there, apart from his all comorbidities he has, then tinea is there in the groin. This is something, a scenario which we see, unfortunately. So that is why the various terminologies have also been defined because of this. So chronic dermatophytosis, which means the total duration of 1 year in spite of treatment. But now the same author has, along with our own group, has redefined it as 6 months, because basically here chronic dermatophytosis is all about the quality of health issue. Quality of health of a person who has suffered it for anything beyond 3 months is bad. It's as bad as many other illnesses in the medicine. Recalcitrant dermatophytosis is basically an umbrella term. It is basically a patient who has taken treatment, but still the disease is not going, and he has taken it probably at a relatively for a proper dosage and proper duration of time. Despite that, the disease is not going due to various reasons. It could include the because of the prior steroid abuse, maybe comorbidities associated with like cancers and other things. Maybe he's on systemic steroids for some other reasons like SLE or pemphigus, or is on immunosuppressants for psoriasis. All these patients, they often continue to have these fungal infections persisting. So they all come to a pool of recalcitrant. It's an umbrella terminology. And recurrent dermatophytosis is something which recurs. You believe that clinically everything is gone. When you see patient is happy, doctor is happy at the end of 3 or 4 weeks of treatment. Then next 1 month later, the patient comes back, says that, doctor, I've got the infection in the same site where I had infection earlier. That is recurrent dermatophytosis. So we have huge burden globally as well, apart from in India. In Indian scenario, I believe this is 36.6 to 78. It must be hospital studies. I don't think the population study will be so much, but that's what is the frequency rather than prevalence. I would use the word frequency of occurrence of infection is so high, anywhere between 30 to 70%. And these are the various treatment options we have. But what we understand today is the current scenario almost always requires a systemic therapy unless contraindicated. You hardly get to see a patient who is, I'm talking about the perspectives of dermatologists, that he has come with a single lesion or 2 lesion. If you get one, your day is done. You probably got a chance to prescribe topical therapy alone. But despite treating them with topical therapy as minimal disease, you see them recurrence. So combination therapy with both topical as well as systemic is currently practiced across India in order to give the best therapeutic outcome. So there has been several, I won't say several, few, authors have come up with some form of guidelines, and we ourselves from when I was a convener of IID Well Task Force on Recalcitrant Dermatophytosis, we also brought one guidelines for the management, which is a consensus guidelines, which was published last year in Indian Dermatology Online Journal. So according to that, we also defined, how we should treat a neo case, how we should treat a recalcitrant case. According to us, all 4 drugs, which are like terbinafine, itraconazole, grisophulvin, and the fluconazole are relevant in the management for us, because at least in certain scenario we have to use. For example, grisophulvin is a indispensable drug in tinea capitis, or maybe it can be used when other drugs fail. At least you try it out at a higher dose, maybe 750 milligram or 1000 milligram. Terbinafine is an indispensable drug, although we know that its efficacy may be lacking due to development of resistance, which is proven now. But still, it's a drug relevant, because when somebody has comorbidities and polypharmacy, terbinafine has the least interaction. So you need to, and terbinafine is relatively safe in cardiac patients. Whereas itraconazole is one which we all know we are using it to the maximum, and its growth in the market itself testifies it. So it's a drug which almost all of us prescribe, and we have more confidence in itraconazole because that's the best currently, considering the response, not just the response, it's also the time duration taken for the itraconazole response is much faster as compared. It's my own experience. It's much faster compared to other drugs. So there have been even studies to say, some people are using combination of systemic antifungals, which personally we don't recommend as of now. But yes, who knows, in future anything is possible if we have this huge pool of recalcitrant. This is what we brought according to our consensus guidelines. This is what we have been proposing. Itraconazole, we should give it for at least 3 weeks. That is what we are recommending. If you are using terbinafine, 4 weeks. Grisophulvin and well as fluconazole, we recommend it for 6 to 8 weeks. So that is the scenario. If you read the Western textbook, you would see itraconazole 1 to 2 weeks. And 1 to 2 weeks, I think all our mentagrophytes will be laughing at us. So definitely, it's not absolutely current scenario in India. It's absolutely not possible. Now, coming to itraconazole once again, itraconazole, as was just mentioned, it is probably the best molecule, considering the reliability in its response rate. Although it's a relatively old molecule, but it was not used frequently by us in dermatophytosis because it's an important drug in the management of some of the systemic mycosis and also subcutaneous mycosis. Like we use it a lot in chromomycosis. Even fluconazole, primarily a drug for candidiasis and a certain internal mycotic disorder. But we are using it because we have scenario like we have patient, for example, somebody with a hepatic disease. Relatively safer molecule is fluconazole in them. So it's become, all drugs have become relevant considering the scenarios that we are dealing with. But by and large, I think still itraconazole and probably next is terbinafine. These are the two molecules relative. Coming to the itraconazole, it's a broad spectrum antifungal. So good thing about itraconazole, somebody who has an onychomycosis as well. There again, itraconazole would work, and also terbinafine for that matter. It also works. So it's got the best when you go through the MIC profiles. Itraconazole is the best in the systemic. So that's why itraconazole perhaps still continues to work, and you don't see the failures with itraconazole as frequently as probably with the other oral antifungals. But still, we have an issue with the itraconazole, which I am coming to it later on. So this is yet again, the same British Journal of Dermatology, which mentions, the response rate, cure rates with itraconazole is much higher as compared to any other systemic antifungals. Now coming to what I was just going to talk about, that is why, when we have itraconazole, why we need a new formulation of itraconazole. That's because of this. The first and the foremost, we have huge number of patients who are dependent on the PPIs or other forms of acid lowering. I'm coming to the fifth point first. This is the scenario. We have patients who are on multiple drugs. They are on NSAIDs, they are on steroids. They have to take PPIs, otherwise probably they might develop a gastric ulcer. So in such patients who have been on omeprazole or other acid lowering drugs, if he develops a fungal infection, then obviously you have the conventional itraconazole whose bioavailability as such is about 55%. It is further going to drop. So that means itraconazole is going to fail. That's one thing. And second thing is, we have people who are absolutely busy. Sometimes they miss their breakfast. It's common with even student community. I see that breakfast is not there at all. They directly have their lunch with the breakfast. We often call it as brunch. So these are the people where you need to give itraconazole. Suppose you want to give a dose of 100 BD, then morning dose he's going to skip, because, or even if he takes it empty stomach, perhaps the efficacy of that molecule is going to further drop. Then we also know that when conventional itraconazole, even the original study by the innovator itself says, it can be as low as in certain individuals 17 or 18%. That means there is a huge inter-patient and intra-patient variability. In the same patient, the dosage, it may vary. The absorption may vary from time to time. So that is the problem with the conventional itraconazole. A beautiful molecule, quite a safe molecule, but it has the conventional molecule has got its own, drawbacks, and what it leads to all the lesser bioavailability. And very important is, if somebody has an achlorhydria, that means he's not capable of synthesizing the hydrochloric acid in his stomach in sufficient quantity, then the drug may not absorb at all, because it's so much dependent. Because the itraconazole in its conventional formulation with the HPMC, it has to be released in the stomach, and from there it goes to the duodenum and where it gets absorbed. So it has a dependency on acid, and that is what happens if somebody takes omeprazole. The absorption drops. So these are some of the drawbacks. Otherwise, it's a wonderful molecule, both in managing dermatophytosis in India and various other conditions we use. I use it in chromomycosis. I use it in some of the mycetomas, the eumycetomas. We have also used it in long back in management of many other dermatosis, fungal infections. And that is the story about the conventional. So it is a good molecule, but with certain drawbacks. So can we have a newer formulation wherein it can overcome all these issues? There's one more issue which is not apart from the PPAs. The itraconazole also has got quite a few interactions, especially with drugs which are metabolized through cytochrome P450 system. So I'm coming back to now conventional. As I mentioned, it's manufactured using the hydroxypropyl methyl cellulose polymer. Now these polymers get dissolved and released in the acidic environment in stomach, and from there it goes to the formulation of itraconazole dependent on gastric. So it is absorbed no doubt in the duodenum, but it's released in the stomach, because from HPMC, if it has to come out, it requires the acid. So primary site of itraconazole absorption is duodenum, but ionization and precipitation in large quantity of the drug occurs in stomach because it has to pass through the stomach, then it comes to the duodenum. Very small quality reaches to the site of absorption. That is why the bioavailability is 55%. And because each individual's make is different, then each individual can absorb to a different proportions, and that is why intersubject. In some person, it may be absorption maybe 55%, but you cannot say his own cousin may have the same amount of absorption. It may be hardly about 40%, or yet another person may have even lower. If he has a lower acid content in the stomach, the bioavailability may drop to 25%. So it has got a wide variation from individual to individual. The absorption capacity of an individual with itraconazole can vary from it can vary so much. The most common cause of variability is the local condition in the stomach, especially the pH and the transit time, how long it takes. So longer it takes, more and more ionization happens. Acid secretion and the transit time in stomach are highly variable, and that's why the variability is associated with unpredictable clinical outcome. And apart from that, it has food interaction. What do you mean by food interaction? You need to take it with stomach, with food. Very important, because once somebody takes the food, the stomach gets stimulated and the acid secretion happens. And it's never the conventional capsule formulation of itraconazole should not be taken in empty stomach. If it's taken, definitely the bioavailability drops. But it's not true with the oral solution. Oral solution can be taken with the empty stomach. It can be, in fact, very important is to make the stomach to secrete more and more acid. Perhaps with the fatty meal, if it's taken, the absorption is good. And also, the manufacturer itself recommends that it can be taken with acidic beverages for its better absorption, because finally what it comes to, how you can increase the gastric acidity. So gastric pH alteration due to co-administered PPI and acidic beverage can significantly reduce the bioavailability of the itraconazole. With simultaneous administration of both drugs, the absorption and bioavailability conventional itraconazole decreased, and hence it's preferred to be avoided with the acid lowering drugs. But that's not practical in several situations. We often do that, if somebody has a PPI, he has to take it in the morning. I often advocate itraconazole 2HS. That means I advocate them to take 2 capsules in the night, so that the effect of the PPI is much less, since he has taken in the morning. Night, probably its effect is much less, and expecting a better bioavailability. Now coming to the newer formulation, which contains, as I mentioned, it is HPMCP. It means hydroxypropyl methyl cellulose phthalate polymer. It's highly resistant in the acidic environment. That means it can carry the itraconazole without disturbing it through the stomach, and it can enter the duodenum, where the absorption primarily happens. So that is how the HPMCP is different than HPMC. When it is in HPMC formulation, it has to be pellets, and when it is HPMCP, it is not in pellets; it's in powder form. So it's a formulation to formulation. There's a huge difference. So super bioavailable itraconazole has received regulatory approval in the US and in number of European market. Although in US it's available in 65 milligram capsules. So these are some of the brands which are available across the world: the Lozonac, Tolsura, and Itrajan. So these are the things. So coming back to the advantages, since we have discussed the disadvantages of conventional, we can understand the advantages easily. It's independent of requirement of an acidic environment dissolution. HPMCP polymer highly resistant to the acidic environment of the stomach, get dissolved, and when exposed to the neutral alkaline environment in the proximal small intestine, enhances the drug. So that means almost 100% of the drug is available at the site of absorption, that is duodenum. Whereas when it's with conventional, a lot of itraconazole may be lost, or it may get ionized in the stomach, and a lesser amount may be available. But having said, let me tell something else. Probably I can tell it later. Not that the convention is out of context now. No, it's not. I'll tell you why a little later. HPMCP polymer in super bioavailable itraconazole enhances its dissolution and intestinal absorption and greater bioavailability than the conventional. So relative bioavailability, when you compare conventional, and is 173. So that means it is almost 1.7 times more absorbed as compared to, almost 2 times better absorbed as compared to the conventional itraconazole. So other thing is there's no interaction. That means, whether somebody takes it with food or empty stomach, it doesn't make a difference with the super bioavailable formulation. So food interaction is not, because food is likely to alter the gastric pH, and gastric pH has nothing to do with HPMCP, that MCP associated itraconazole, that is super bioavailable itraconazole. So there are studies to say both in fasting as well as the fed status regarding the interaction with the food, and it both both the status super bioavailable itraconazole demonstrated similar concentration at the end of the dosing interval, with the modestly lower total and peak ITZ absorbed being found in the fed state and fasting state ratio. So it means, whether somebody takes in fed and fasting state, it doesn't make a huge difference when somebody consumes super. Whereas in conventional itraconazole, definitely the bioavailability drops if somebody takes it in fed status. And no interaction. In fact, the study says, there's one study says, if it's taken with an PPI, then the absorption may go higher. It says, the absorption, maybe to what extent it's clinically reliable, we don't know, but it says, that study says, finally the itraconazole exposure is much higher if somebody has taken with PPI. So PPI, it do not interferes with the absorption of super bioavailable itraconazole. This may actually, it also improves the convenience of the patient. So if somebody is on PPI, you can comfortably ask him to take. You don't have to discontinue. Otherwise, we often tell, how bad is your gastric acid peptic problem? So can you discontinue itraconazole for some time? There are two drugs one needs to be extremely careful when you prescribe itraconazole. That is, I'm talking conventional. The first one is the PPI, because it is likely to PPI or ranitidine or any of these H2 blockers or the antacids also. So that first thing is, you need to tell them you have to discontinue, but sometimes patients can't discontinue them at all. So we need to tell them you need to. Second drug one should be extremely careful, especially in the older individuals who are on the statins. Statins and itraconazole can have interaction, but this statins interaction will continue with the conventional as well as super bioavailable. It's not going to change much. But with the PPI interaction, it's definitely you need not worry when you are doing super bioavailable. An open label 2 treatment fixed sequence comparative bioavailability study compared pharmacokinetics of a single oral dose of super bioavailable itraconazole capsule with or without co-administration with daily omeprazole. That's what I was telling. Concomitant omeprazole, there was a 22% increase in the total plasma exposure of itraconazole. So indicating that perhaps the presence of omeprazole, though there is an interaction, but it is for the betterment. But you need to be worried that excessive concentration of itraconazole may perhaps increase the adverse effects also. So one needs to be careful about it. But by and large, it's what we are looking at, high plasma concentration to quickly neutralize the fungal cells. So that may be achieved better with this. The summary of itraconazole pharmacokinetics, you can see this the trough 0 to infinite and Cmax. If you see everywhere with the super bioavailable itraconazole, you see here 2640, whereas as compared when while on omeprazole it is much higher. The 0 to infinite area under curve 28462 versus 3478, and the Cmax is 213 278. So that means you have definitely much better profiles, pharmacokinetic profile, when it is taken with the omeprazole. And also because the gastric acidity dependency is very, very low, not low, almost nil. So no inter and intra patient variability is there. So super bioavailable itraconazole is independent of the acid food and targeted drug release at the duodenum. So there is a uniform and uninterrupted absorption. So variability is among the patient is very, very less likely. All these factors are responsible for. So one, you can be very sure that when you're prescribing super bioavailable itraconazole, that perhaps you don't have to think again, and who knows whether the itraconazole absorbs well in this patient or not. Perhaps almost all patients who takes it gets absorbed. Rapid attainment of consistent serum levels. It's a study by Lindesay. It's super bioavailable itraconazole achieves therapeutic concentration more quickly, achieved significantly higher mean trough levels compared to conventional itraconazole. So therapeutic concentration was much quicker with the super bioavailable. So that means 6 days for the super bioavailable were 14 days. So therapeutic concentration obtained is much faster. And we also see this, in clinical practice, Usually the itraconazole response starts from the second week. So probably the therapeutic concentration starts 7 to 14 days, and by 14 days you see generally an excellent response. That doesn't mean you stop it, you need to continue. Definitely in current scenario, you may have to continue for minimum of 4 to 6 weeks also maybe. So that is how it is. So whereas when you give super bioavailable, I have not put a real mind into that. I think we should call the patient in 7 days and see how quickly they respond. So within 6 days, they are likely to achieve the therapeutic concentration. So there are studies, bioequivalence studies, real world study with itraconazole in India. They have a couple of studies are published. Comparative study of super bioavailable itraconazole with conventional itraconazole. So this is published bioequivalence pharmacokinetic comparison of super bioavailable with conventional and open label, 3 days loading dose and 15 days steady state administration. The extent of the absorption and safety and tolerability was assessed. And if you see, the super bioavailable has got a much higher. You can see all these pharmacokinetic parameters are much better here as compared to the conventional itraconazole. And what one has to understand is, so overall the bioavailability is much higher, and you see the dosage here again is 50 versus 100 milligram. Then you have super bioavailable itraconazole capsules are bioequivalent to 100 milligram. So you can say that it's almost equal. Volunteers receiving super bioavailable itraconazole formulation were more likely to reach the therapeutic drug levels than volunteers receiving conventional itraconazole formulation. So this is the outcome of the study. So safety profile was similar in both studies. Then real world studies, you have this the Indian studies which have recently been published. The real world retrospective data analysis was conducted in 346 dermatologists across India. So out of 4625 patient data, 2743 were included in the final analysis. Then primary outcome was the treatment response evaluated at the end of 4 weeks. 70% patient achieved clearance in the body BSA. Mean total symptom score was reduced to 0.741 from 7.291. That means, overall the clinical response was much better. The mean BSA score was reduced from 1.96 to 0.38. So that means the overall body surface area clearance was also much better. This is a study, Indian study, multicentric, and this is what the conclusion. Patients treated with super bioavailable showed greater improvement. This is not a comparative study, it's just about the efficacy of a super bioavailable. And then there is a comparative study, clinical study, multicentric, super bioavailable and conventional. The primary effectiveness endpoint percentage was complete in the percentage of patients receiving complete cure at 4 weeks was 56% for super bioavailable as compared to 34% at the end of 4 weeks. Outcome of patients at 4 weeks was you can see here the remarkable improvement was seen in the super bioavailable group as compared to the conventional group. So 69% patients achieving statistically significant complete clearance of their lesions in super bioavailable itraconazole group compared to conventional itraconazole group was observed, indicating that was more effective with similar safety profile as compared to conventional itraconazole. So where are we focusing its indication on? In superficial mycosis like dermatophytosis, tinea cruris, and corporis. Even in systemic mycosis, it can be used, for example, aspergillosis, candidiasis, cryptococcosis, porotrichosis, paracoccidial blastomycosis. You want to add to that blastomycosis as well. So if you are using 100 milligram of conventional itraconazole, so you just need to halve the dose, that is itraconazole 50 mg. So there are many people use 100 mg OD, perhaps you can use 50 mg OD, but my personal choice is 50 mg BD itraconazole in almost all situations in adults. The recommended doses of itraconazole 50 mg is thereafter half the recommended doses. That's all. That's 50 mg. So contraindications, hypersensitivity, obviously, if it is there, then co-administration of drugs with the CYP3A4 substrate with the itraconazole and congestive cardiac failure, one should avoid. That's what I was talking about. Although itraconazole has got a wonderful renal safety profile, but its cardiac safety is not good. So if somebody has got a subclinical congestive cardiac failure, if he takes itraconazole because of the negative inotropic effect of itraconazole, they may actually frankly land up in congestive cardiac failure. So one needs to be a little careful when you're giving it longer term. Always look for if they develop edema of the feet. So that's probably an early indication. So you need to be a little careful. People who have developed edema, you prefer to discontinue this drug. So one needs to be careful about it. So most frequent is headache, abdominal pain, nausea, and most serious is allergic reaction, congestive cardiac failure, pulmonary edema, pancreatitis, serious hepatotoxicity, which is rarely reported, although because we use itraconazole in India such a huge quantity, and I don't think there's any, to the best of my knowledge, no hepatotoxicity. None of my friends have experienced serious hepatotoxicity. There may be elevation in the enzyme levels, which we get to see when we do a lefty, but generally it returns back when you discontinue. Use in special population, pediatrics, the use of itraconazole capsules in pediatrics is not recommended, but it is a safe molecule. I wouldn't say it's you have to. It's an off-label. If you use it in pediatric, you can't call it as a approved indication. But anything above 2 years, itraconazole is relatively safe. Relatively safe. Less than 2 years, it's preferred to avoid. But sometimes when situation is such that you cannot do it without, then we have to use it. But we need to be extra cautious. Limited data is available in the pediatric. In pregnancy, limited information on the use of itraconazole during pregnancy. Itraconazole capsule must not be used during pregnancy except for life-threatening cases. Used in special population, hepatic impairment and renal. Limited data is available on the oral itraconazole in patient, but I would just add renal safety is fairly good with the itraconazole. You don't need a huge dosage modification, but when it comes to terbinafine, obviously, somebody has got a creatinine clearance rate or rate is much lower, then you may have to modify the doses of terbinafine. But itraconazole, because 85% of the itraconazole is excreted to the stomach, through the GIT. So only 15% probably. I may not be exactly with the number, but it's much less with the renal clearance. So take home with super bioavailable fungal infections are increasing in prevalence, obviously, and it's causing a serious quality of life issues and also financial burden to the patients afflicted or the family afflicted, because you don't get to see nowadays single patient. You don't normally get several patients in the family being affected. Itraconazole is a broad spectrum antifungal, plays a vital role in the management, and finally, the conventional itraconazole poses several limitations with the lower bioavailability, food and acid. But as I told you in the beginning, let's not just wash away with our conventional. Conventional is still, because two reasons. One is the approval. So approval of the, even today, approval of super bioavailable is for the serious infections only. So we are trying to develop now. You have few Indian studies because of which we are using it in the regular indications like the dermatophytosis. That's one reason. And second reason is in pediatric age group. Again, pediatric age group, although the safety with the convention also is not huge, safety publications on the safety in pediatric is not so much, but still it has some. It's being used in tinea capitis. It's being used in patients with the systemic and pediatric patients with immunosuppressed pediatric patients. They are receiving. So there is some data available on conventional itraconazole. We hardly have any data on the super bioavailable. So itraconazole, even in its conventional formulation, is definitely it's relevant today, and it will continue to remain in the market. There's no doubt about that. But this super bioavailable itraconazole, which is a new addition to the basket in the management of fungal infections in India, is a great welcome, because it has definitely got advantages over the conventional molecule, and I have already been using it for since 1 year, and I definitely feel it works definitely. So it's a newer technology. pH dependency is much less, and no interaction with acid and food. And so it's, as I mentioned, so it can be, it has a scope to be one of the important molecule, future or present, in the management of superficial fungal infection because of its better bioavailability. So thank you very much for your listening. I think it was quite an exhaustive presentation, but I think there may be a lot of doubts in the mind of dermatologists who are prescribing already, or maybe going to prescribe super bioavailable itraconazole. So I think this presentation would have helped you a bit in understanding and also to have more confidence in starting this the new formulation super biology. Yeah, over to Dr. Bhagyashree.
Thank you so much, sir, for such a wonderful presentation. And yes, it will definitely help our participant to understand the new technology and new drugs, that is super viable itraconazole. So I request all the participants to put their any questions in the question box, please. And till they put their questions, and for setting the background, just I have one question, that in your clinical practice, where does the itraconazole stands as a therapy for dermatophytosis, especially the recalcitrant one?
Now it's we have reached a stage wherein we are so much dependent on itraconazole in almost every case.
Right.
That's become so. But where would I would rather put it like this, where I wouldn't like to use an itraconazole. That's the situation now. Truth is this.
Right.
So I don't want to run away from I don't want to be very yeah. This is the truth. We all know this. Yeah, once upon a time we were using a lot of terbinafine, and failure with terbinafine has become obvious. At least in my region where I think when I think probably 25% patients would respond. That's my wild guess. It's not that they don't respond, but that number is dropping, and 25 or 30% is not acceptable. You can't take a drug which is 25% effective. How can I take that drug? Well, I would use it when I cannot use other drugs which are more efficacious. I know that when I use itraconazole, almost all patients respond, unless there is some issues like if he's on concomitantly with the uh, proton pump inhibitors also, where now this super bioavailable itraconazole has come, which can overcome that disadvantage also, or in patients like pediatric patients, or in pregnancy, where only drug which I can use is terbinafine in pregnancy because it has got a best pregnancy safety as per recently published data, which says it's almost no. It says almost no fetal malformations have obtained or has occurred, or in patients with cardiac failure patients, wherein I cannot use it. But otherwise, in almost all patients where systemic antifungal is required, my choice is definitely itraconazole. That's how I can put it. Whether it is recalcitrant in naive patient, yes, I would like to try terbinafine initially, but that number is very small now. Where do I get naive patients? In a day, also I get one. I become very happy. So that number is further low. So that's the reason why I would put it that way. This way, your question, I'm going to totally twist it. That I would rather look at where I don't
Don't
want to use
use
the
it.
itraconazole.
Yes,
Yeah,
right.
that's it.
So, we have so many questions from our participants. So,
Okay.
Dr. Sandeep, Dr. Indranath, she's asking that what should be the optimum dose of duration of Mycoclear SB, that is super viable itraconazole, in a normal tinea corporis in adult patient.
Yeah. Now, see, what I would put it this way is whether you are using super bioavailable or the conventional, the duration isn't going to change. First thing, it's only dose is going to change. Here you are using 50 mg if you are using 100 mg there. So that's the thing. So duration is going to be the same. Now, how would I decide on the duration of treatment? It is only based on my clinical follow-up. So I would call a patient, give it my minimum duration of treatment with itraconazole is 3 weeks now. Some people give 4 weeks. There are many people, they are much more aggressive. I won't say aggressive because it all depends on individuals. So I give it for 3 weeks. After 3 weeks, I follow them up. And if I'm in an institution, I often take a follow-up KOH mount, wherein to see whether I have a micro. But that doesn't happen. To be honest, this is a real world situation. In clinic, I may not be able to do it in every patient, or probably I wouldn't do it at all. So let's be honest. So in such cases, we are basically relying on clinical symptoms. I would see if there is a scaling. I would see if there is an inflammation. I would see if there is a pruritus. And based on that judgment, I would definitely add another 1 to 3 weeks, maybe up to 6 weeks I would give. And if there is some issues, I would do an LFT at that time. At 3 weeks, I would do. Not in every cases, but quite often I do it at 3 weeks. This is how I manage. So I wouldn't say, this is the standard or something. I'm just telling the thing. I would do an LFT at the baseline if there is some hepatic issue in that patient. For example, he's alcoholic or he has had a recent jaundice. He's on other drugs which are hepatotoxic. I would do it at baseline only. So this is how I manage. At 3 weeks, I would decide at one. So by and large, my treatment duration has become 4 to 6 weeks. But there are patients whom I have given for 3 months also. There are patients whom I have given for 6 months also, you believe me or not. It's 4 or 5 months I have given some patients because I was seeing, mycological clearance wasn't there in such patients. So I had to continue. That's how it is.
Okay.
So
So,
duration is not, the answer is duration is not going to change. Whether you are using the conventional or super bioavailable, it's going to continue, remain the same thing.
So I hope Dr. Indra, you got your answer that about the duration of the treatment. The next question is from Dr. Indra itself. So she is asking, will excess of viability of Heteroconazole have any effect on compromised immune system?
Thank you, Dr. Inda. It's a very innovative question and very thought-provoking. What I understand is, itraconazole per se, we do not have any evidence, to the best of my knowledge, to say that it is likely to interfere in the immune system of an individual. Although it has got an anti-inflammatory property, it has some angiosuppressive property, which means it can because in fact because of that itraconazole is also used in certain infantile hemangiomas to treat. So that means it has got some kind of effect on the smaller vessels, capillaries and smaller vessels. But to the best of my knowledge, it probably doesn't have any effect on the higher bioavailability. Yes, you need to be a little careful with the cardiac toxicity. That's one thing which comes in my mind. Apart from that, I don't think there's something concerned. But as you mentioned, I think it's a very thought-provoking. Probably I need to do a little homework once I finish this webinar.
Yeah, definitely. So, sir, Dr. Rajesh, he is asking, so will more viability will translate into the increase in adverse effects for the drugs or any interactions?
Yeah, exactly. This is exactly, I think the previous question also was addressing. See, two things here when we use an itraconazole. Number one is the adverse effects are due to the serum levels. Yes, I agree. But here, what has happened here is we have forgotten the fact that we are not giving 100 mg of superbio, right? We are giving 50 mg. So finally, what enters the bloodstream is more or less equal to that of conventional, maybe marginally higher because the intersubject variability is low. So here, I don't think that question is so much relevant because you are not giving 100. I agree, 100 mg of superbioavailable BD, if it was given, then one need to be worried about. Finally, the amount that reaches the serum, both in conventional and superbioavailable, should be more or less same, except in those patients where there is a, what we talk about, so intersubject variability. In those patients where the absorption is poor, there definitely he is going to have much lesser concentration of that is only with the conventional. So I don't think that question is highly relevant. But yes, when somebody takes with PPI, that's something which says 28% higher exposure of itraconazole. So in such patients, I think one needs to be a little careful, especially if he's a cardiac patient and all. So that's one thing. So that's something which we need to. Otherwise, finally, instead of 100, you are giving 50 because it has got a higher superbioavailability. So it's not highly relevant, that question. But yes, if there is an interaction which is likely to further increase the itraconazole level in the blood, you need to be extra careful.
Yes. Yes. So next question from Dr. Harnath. So what advice will you give, sir, for the long-term care of recurrent tinea?
So the recurrent tinea is a game of comprehensive management. I need to look at if there is a apart from the compliance. Compliance is very important. We need to tell them about the compliance and regular follow-up. This is very important, which I tell in recurrent tinea, because many recurrent tinea they occur because they, at the end of 3 weeks, they feel it's everything is done, everything is gone. They all get the feeling, good feeling, yeah, I'm got rid of the disease. But they often, there's no mycological cure. There's only clinical cure. So which indicates, after 2 to 3 weeks, they come back again with the repeated infection, recurrent infection. That's the first thing. So why these recurrence occur? Because so most of the times when the patient comes for follow-up, we generally see that subtle signs of inflammation. With dermatologists, generally, our trained eyes, we generally make a note of that and we continue the treatment. That doesn't happen. Patients once is off pruritus, he's likely to stop. So this is something which is very important in a recurrence. That's one. And second thing is about the recurrences can also be due to hygiene issues. You need to tell them a lot. You know, you should not. It's often possible that one person in the family takes the treatment, the other person doesn't take. So other person continues to be infective to other members in the family. And I often notice that the recurrences occur in the same people. If there are 10 people in the family, 5 people gets it. The other 5 people don't get it at all. That means there is some CMI related issue is there. So those people with the good CMI against dermatophytosis, probably they don't get infection at all. Otherwise, why only 5 get it? And the same 5 get it again and again. So that means, this person who is getting it recurrence, he might have some CMI issue. So that means he has to make sure that he doesn't get it again from another person in the family. So he needs to practice, perhaps, we need to tell them to use separate towels. And also, I also feel that if in patients with the recurrent tinea, they also have this, especially with pentagrophyte, there are some evidence also to say that, these fomites remain in the, these spores remain active in the fomites like clots for months, not days. So that means, he needs to take care of the cloths. Very important is cloths. And also, bed linen, the pillow covers, the hosiris, the sofa covers, all these things, they need to be washed and preferably soaked in hot water, not warm water, hot water, maybe 70 degrees C or so, for at least 20 minutes to 30 minutes, and then it should be washed. If it's not a rainy season, dry it in sunlight very well, or iron those. So this is how the heat kills the spores. It's liable to heat, these spores are. So people believe, I put a drop of Dettol to the water and all fungus is going to die. That's not going to happen with this fungus. So this needs to be, these are the 3 minimum things I would say: hygiene advice, taking care of the fomites, and third thing is, regarding the compliance is very important. So these are the 3 issues which I would address, and I think many patients have been doing better with the recurrences.
Yes, yes, sir, definitely. The spores, they are also playing important role in the transfer of the disease. So
Sure.
yes. So there is another question from Dr. Pranay, that can we use superbiable itraconazole in treatment of onychomycosis as a pulse therapy?
Absolutely. Absolutely. So instead of 100 BD for 7 days, you make it 100 BD, sorry, 102 BD for 7 days. You give 50 mg, 2 BD per. So just half the dose. So there it is 200 mg twice a day. I would rather call it as 100 mg 2 BD rather than 200 mg, because 200 mg capsule, probably conventional, it cannot have good bioavailability. 100 mg 2 capsules twice a day for 7 days is one pulse of, which you would give at least 2 to 3 pulses, 2 pulses for the minimum of 2 pulses, I would say, for the fingernail, and minimum of 3 pulses for the toenails. So instead of that, you give 50 mg. In fact, there is a clinical trial on onychomycosis with super bioavailable itraconazole. So it's submitted to FDA. I think probably this molecule may get a nod for super bioavailable, may get a nod from FDA also for onychomycosis. It's quite likely to. I cannot say because I'm not FDA, but they have to assess those results, and then they will probably decide on approval of super bioavailable. So it can be used. Yes.
So, sir, Dr. S.K. Punshi, he's asking that don't you feel that there is epidemic of fungal infection in India right now? Because 90% of OPD, it is because it is of fungal infections only.
Yeah,
So
Punchi sir, I agree with you that we have epidemic. I think I don't know exactly what terminology can be used in, somebody, an epidemiologist can properly use this. Definitely there's an epidemic, there's no doubt. And we have had recently a mid-cuticon, which I was a scientific chair. We invited a speaker from Sri Lanka, and similar situation is happening in Sri Lanka. I heard in Bangla there is a similar, Nepal there is a similar situation. It's not just in India. So in Southeast Asian countries, I heard even in to some extent in Mauritius. I'm sorry, uh, in Singapore, there are quite a few cases of recurrent dermatophytosis, recalcitrant dermatophytosis in all these countries too. So whether to call it as a epidemic or is it an hyper-endemic situation, I think somebody who has got a good knowledge, but definitely there's no doubt that we have epidemic. We clearly have an increased number of load of this thing, as Punshi sir rightly mentioned. In some of the institutions, it may be as high as 90%. We did a study from when I was uh, convener of ideal task force, and we found this was a study done in 2018-19. We found it's about 30%. The recalcitrant dermatophytosis I'm talking about, and because about 30% of all cases qualified as per the strict definitions into recalcitrant, chronic and recurrent dermatophytosis. In fact, in my institution, it was up to 45%. So almost 50% of the patients account to the recalcitrant dermatophytosis. Yeah.
Yes, sir. So same question. So a question from Dr. Pulshi that what is the rationale of combining terbinafine and itraconazole? So can we combine these two combinations?
First of all, the question of rationale doesn't come. It is not a routine combination. So I would say if it's a tuberculosis, why you use the 4 drugs, there is a rationale and very strong rationale. But here we have a situation. This is practiced in cases where you are frustrated with the fungal infection, both the patient and the dermatologist. That is where I think I use a combination of 2 drug combination. I believe Dr. Kunshi is referring to the combination of systemic itraconazole and systemic terbinafine. I'm not talking about the topical terbinafine. Topical terbinafine, well, there is some kind of rationale that itraconazole is oral, which is allylamine. Terbinafine is is an azole. It's a triazole, and here we have a drug which is allylamine. So you are trying to make something like a multi-drug therapy, trying to use it. But systemic, as of now, it's not a routine practice. Not many people are using it. I think there are people who use it. I agree with that. So, but the rationale is that 2 things are very important when we club 2 drugs. Number one is there should be in vitro evidence to say that this combination has got a synergistic effect. And when it comes to molds like dermatophytes, to prove that you need to do what is called checkerboard analysis. And there's hardly any checkerboard. Now, one publication has come on checkerboard analysis of the combination of antifungal drugs in the dermatophytosis. Not many studies are there, very few studies are there. So with the current evidence, very difficult to say that the rationale is that, because in vitro study. Then we need to have clinical studies, the second thing. There are a couple of clinical studies which are already published in the Indian literature on the combination. It says, there may be slight superiority of the itraconazole terbinafine combination over either itraconazole or terbinafine alone. So considering that, probably there is some rationale, but I think it's too early to say. But as of now, I think we should use it in only those few cases where you have found that either there is no response at all, or you see that patient is dependent on a particular drug for a very, very long time. Try to give 2 drugs, but albeit you need to be extremely careful with the liver toxicity. In these cases, you need to definitely do a baseline liver toxicity and periodic liver toxicity profiles. The LFT should be done when you're combining, because both are hepatotoxic drugs. So we need to be extra careful about that.
Yes, sir. Then Dr. Kala, she's asking that which is antifungal, it is safe in elderly and children also. So can we use superviable itraconazole in these patients?
Elderly, yes. I don't think there's any major issues with the itraconazole, because a healthy elderly patient is like anyone else. If he's not having renal, hepatic, or cardiac issues. But the question comes if he has got comorbidities and he is on polypharmacy. Then you need to be careful. Just you have to assess whether the drugs he's taking has interaction with itraconazole. If he doesn't have interaction with itraconazole, these drugs, yeah, one can give it in. But in children, as itraconazole is quite safe, in my opinion, after 2 years. Less than 2 years, it's preferred to avoid. Infants and young children, it may be better to avoid itraconazole because safety data is very much grossly lacking. After 2 years, there is a good amount of data because of the tinea capitis. It's used in tinea capitis, and many people use it, and also it has got in other infections, like it's used in aspergillosis and other conditions. So we have some fairly good amount of evidence in older children, but in young children and infants, it's preferred to avoid. Regarding super bioavailable, as of now, the approval is for adults. Can I use in children? Perhaps for me, both super bioavailable and conventional itraconazole is same. It looks like same. It's just that the formulation is different. Finally, the drug is the same, itraconazole. So whatever happens, taking whether see, it's like whether you are going in a Ferrari car or are you going in, I would compare it with yet another, ordinary car. That's a difference. So you go in Ferrari car, you will reach the destination quickly. So that's what is super bioavailable. So it takes you to duodenum quickly, takes the itraconazole to duodenum much faster. Whereas the conventional, it takes to the itraconazole, it may be slow, and when it takes, takes slowly there, perhaps an amount of itraconazole may be lost. So finally, what is going to reach the bloodstream is the itraconazole only. So it probably doesn't make a huge difference, use it in children, but because of lack of evidences in children, so it's as of now, we should use it carefully. And when we are using it, you need to be extra cautious and call them more frequently for follow-ups and all that. So that's all I can say.
Yes, sir. So, sir, there are many more questions, but
Yeah, I'll
because
be
of
fast. You can ask quickly. I'll give
yeah,
one or two
okay.
questions. You can
Okay. So,
quickly.
sir,
I'll answer.
Dr. Shruti, she's asking that how to establish the mycological cure in busy clinical settings.
Busy clinical setting, the only way is to potassium hydroxide mount. Otherwise, nothing else. Culture is difficult, so potassium hydroxide mount at the end of the treatment, 3 weeks or 4 weeks, you call up. If you have a technician, well, it's very handy. Yeah.
Then, sir, Dr. Saurabh is asking, are you using conventional itraconazole or you're shifted to super viable itraconazole?
I use both. I use both. But my prescriptions for super bioavailable, initially I used to use it in very small number. That number has gone up. I use both.
So, sir, there is last question from Dr. Virender. What is the prophylaxis of treatment after the cure?
No, there is no prophylaxis after the cure for any fungal infections. Like, I mean, I'm not talking about any fungal infection. I'm talking about dermatophytosis. There is no concept of prophylaxis in. What we presume is, that we are not doing a mycological cure study at the end of treatment. Are we doing it? No, we are not doing it in every patient. Maybe in a institutional setup, we do it. At least a potassium. Ideally, we should do both potassium hydroxide mount as well as a culture to make sure that the fungus is eliminated. So which we don't do it. So that is the reason why we often overtreat rather than it's a prophylaxis. It's not a prophylaxis. We overtreat, presuming that we are not being able to eliminate the fungus from the skin. So we often give it for 1 week extra or 2 weeks extra. It depends on the individual's experience in a given population. In a given he knows his type of population. So how long to give? So we probably. But when it comes to topical antifungal, it may be a wiser to apply that. What I tell them, apply once a day or twice a day, whichever topical I am using, till the marks go. That is because I just want to tell as long as you can, because marks sometimes persist for 3 months or 4 months. It may not be practical, but often I tell them in order to tell, just to make sure that why marks, because that was the area where the infection was there. So fungal element concentrates there. So I ask them to apply the topical for much longer period of time to make sure that whatever few fungal element which have escaped persisters are also taken care of. They are also killed, or the spores or whatever, to what extent. That's how it is. Yeah.
So, sir, thank you so much for sharing your experience. And it will definitely help our delegates for their day-to-day clinical practice. So, to conclude this our webinar, so super viable itraconazole, it is big breakthrough in the treatment of dermatophytosis. This is new technology, and there is some advantage over the conventional, that is the viability, it is improved. There is no interaction with food and acid lowering agents, so there is improved convenience for the patient, and no inter and intra-patient variability, so there may be predictable outcome. So again, thank you so much, sir, for the wonderful presentation and wonderful discussion. So now I hand over this session to Mr. Manish Rathod, who is marketing head, for his word of thanks. Over to you, Manish.
Thank you, Dr. Bhagishri, for the wonderful moderation.
Thank you so much, sir.
Thank you very much, sir. Thank you very much, everyone. Good evening, everyone. My name is Manish Rathod. I work as a marketing lead with Zydus Liva. Thank you very much to each one for spending their valuable time attending this session. But I'm sure this was worth and spent, because the world has been moving from conventional to the super itraconazole, and I think this is the right time. Then when pandemic is now slowing down, and when we see a lot of patients are visiting clinic and when monsoon is setting up, so this is a time when fungal infection will be on the rise, and we got a very beautiful product in the form of Mycological SB from Zydus Liva, which has been super viable Heteroconazole. Just to say, as I said, the world is moving towards super bioavailable. So we expect, in fact, more strength of Heteroconazole getting converted into super bioavailable worldwide. And from House of Zydus, we make sure that the best of the medicines and formulations we brought for the patients of India. So with this, again, I thank you everyone. I thank Dr. Manjunat Shinoye for sharing his time, sharing his thought, and taking us in a very, very simple way of understanding what is super available and how can it be relevant for the Indian context. So I look forward for more such sessions in the future, sir. And I look forward all the attendees to come back for our next sessions as well. So thank you very much and have a good night and great time. Thank you.
Thank you, Manish.
Thank you so
so
much, sir.
Thank you.